we are in a time of the worst healthcare crisis we've seen in Canada, probably ever. 6 million people without a family doctor. The vast majority of people who do have a family doctor can't get an appointment for at least a week. People cannot access healthcare. We see emergency departments closing, clinics closing. It is really close to a collapse of the system across the country.
All right, Rob, why are we having another health tech conversation on this podcast? What's going on?
Have you looked out the window lately?
No, I've been waiting in line to see my doctor for the last 8 months.
Well, we've been through a lot of our production meetings, as some of our listeners know, and you know, obviously my family's been going through some pretty acute healthcare issues. Seeing my mom is diagnosed with something really pernicious. My dad is 91, has congestive heart failure and dementia, and so I've been in and out of the healthcare system. Both the emergent and the regular healthcare system, I've been living. I might as well be a doctor at this point. And it's become quite clear that it's stuck. And I think if you are in a dire straits and you're about to die, break fix, we're really good at.
Mm-hmm.
Anything that's not that, you're fucked.
Yes.
And so we thought, let's go back and let's revisit some of the conversations we've had in the past. We had Brett from Maple on couple of years ago in the pandemic.
Dr. Brett Belchetz,
Yep.
CEO of Maple.
And founder. And we were like, what is this? What's actually happening? What's happening across Canada?
Mm-hmm.
And what's happening because we're an innovation-focused podcast? What are the innovators doing and how are they navigating the system, especially at a critical point when, at the time of recording, a couple months ago, the federal government and the provincial governments made deals on what new healthcare funding would look like and how that would be spent.
I feel like it was more of a hostage exchange, which I think is another component of this because, we come at this and this podcast in most ways as let's talk about the innovations happening in this country.
Mm-hmm.
And there are certain moments where we just run into the cultural, historical moment and the healthcare conversation that we've been having since the pandemic, when we relaunched the podcast through the pandemic, I think has been, as we get to in this podcast, so much less about the innovation and so much more about the social, government, bureaucratic structures that are impeding that. We had Brett on the podcast during the pandemic. His company Maple was exploding during that time because the provinces had finally opened up, allowing for broader telehealth access because people were stuck at home.
There was panic, right? Like the Canadian Shield we had on as well. It was like, oh shit.
Yes.
Everything's going to shit. We need help.
And when we had Brett on at that time, he was very tired, very busy, but energized. Mm-hmm. We've had him on now again, and he seemed a little bit more frustrated, a little bit more defensive, but I think for good reason, because after all of that good work during the pandemic and kind of being, praised and recognized. Look at these homegrown innovations that we're using to fuel it. There's been a couple of years of, actually, we're not going to do that anymore. And then there have been questions, and as Brett alludes to, political maneuvering around the whole public-private debate. So some of the things that Maple was offering during the pandemic that we desperately needed, that the government was willing to cover, at least in some instances, they're no longer willing to cover. And then that has shot these companies that are just trying to supply technology to better service what is a fundamentally stressed system into a very hot public versus private healthcare debate, which is beyond the scope of this podcast, but we run into because you have CEOs like Brett in the crosshairs. You have solutions that they have that, if we were sick at one period of time 2 years ago, we could utilize, and now we have to pay for. And we have a general fear of privatization across this country, but then also a general frustration and a desire for just something different from our system that we have now. And I'm wondering your thoughts, because I got into it a little bit, because for me, the most energizing parts of the conversations that we had along this line on the podcast have been much more around the limitations, the structural limitations these innovators have to just do their damn job. Like, we've had people on who are like, we could actually register everyone to get vaccinated if Premier Ford would actually like answer an email. Why isn't this? What is the reason why this isn't happening? Why does Dr. Alexandra Greenhill, CEO and CMO of Careteam, still have to communicate with pharmacies over fax? None of this makes sense. And it leads to, I think, those fears and frustrations intersect in ways where it becomes difficult to then parse out the diagnosis and the prescription, I think is where we got to. How do you feel about that component? Because I know beyond your personal experience here, and we also had you on speaking about the startup that you were trying to work on and things like that, there's a personal connection here, but it just doesn't seem like this is an innovation conversation purely.
Not at all.
And if we have it in that silo, it just doesn't seem like it works.
No, not at all. In fact, the reason, so I allude to this on the show, but I helped build the Ontario Telemedicine Network, which was the biggest telemedicine network in the world for a time. And it was funded by Ontario taxpayer money. And we were an agency. We weren't an agency. We were not for profit. And we put a lot of traffic through that platform. And it was about cost avoidance, allowing people to get equal access to care no matter where they were in the province, because that's what the law is in Canada. No matter where you are, you're supposed to have the same quality of care. And the reason why fax machines are used, interestingly, is it's not a technological thing. It's because you can't intercept. I mean, there was a historical reasons. That's how you send a prescription. Mm-hmm. But one of the reasons it's a laggard is you can't intercept a phone call like you can intercept an IP packet. So it's much more secure to send a fax to somebody, believe it or not, than it is to send an email over the internet that can be intercepted along the way with all this patient information. So there are some actual reasons behind this, but to the point that you're making, none of these things it's not really a technology problem. It's what do we want to do as a society, and what risks are we willing to take, and how much are we willing to push it, and what is the cost of the risk benefit analysis. Brett goes into something on the show that I found really interesting. He says that they're white labeling for Nova Scotia, where that's cool. But in Ontario, just offering maple with the M logo on it, not cool. And it feels very much like the ship of Theseus sort of style problem. It's like, they're not making the machine they're not making the stethoscopes in Ontario. They're not making the medical system that sends an email in Ontario. But if that last mile happens to be private, and I'm not necessarily advocating for private care, but there's a whole hell of a lot of private on the way up to the public facing side of this, that it strikes me that these entrepreneurs, and Alex has been doing this for years. She advised Dialogue before they were public. Mm-hmm. She worked with BC-based a private telemedicine company in the OG days, and she spun up a bunch of different companies. So she's been banging her head against this problem for a really long time as well. And so, on the one hand, credit to the entrepreneurs on the show for bothering,
and the doctors.
They're doing both. Doctorpreneurs, exactly. They are subject matter experts, and they continue to bang their head against the system to try to make some sort of change. But it's clear, I think, if you listen to this conversation, that nothing here is a technological problem. It's all about our societal willingness to empower and force our politicians and ourselves to examine what okay looks like and what is unacceptable as a society that is in the 21st century, and is subject to all of these crazy technologies that have yet to be regulated, when we could just be paying attention to the ones that we already have in our hands.
Yes. So 2 things I want to say before we get to this conversation. One, I'm the only person on this podcast who's not a subject matter expert in this space whatsoever.
My expertise is 10 years old.
I am just an angry Canadian frustrated by a system that doesn't function, paying close attention to political leaders that either seem to be actively undermining the system for financial benefit to the point of underfunding it across the spectrum, or, as is noted on this podcast, maybe holding to a messaging standard that doesn't match reality right now because the system has been underfunded, under-optimized, under-refreshed, right? And I think it's where we get to on this podcast is an important articulation that it isn't just a public versus private. It is not a paper versus new tech. There has to be a holistic approach to this system. And there are things to our approach to healthcare in Canada that are absolutely nonsensical The only way we're going to solve it is if the innovators, the health providers, and the political owners of this get together and say, we want to solve it. And I would, knowing that at certain points in this podcast, it gets a little yelly, understand that you just can't choose a side on a black and white divide right now. If we care about this stuff, we've got to dig in. And hey, that's what we do on this podcast. So enjoy the conversation. The last time that we had you on this podcast, it was the middle of the pandemic, and we wanted to speak with you because it seemed as though all the red tape and circumstances and conditions that were inhibiting actual health innovation across Canada were being slowly removed to allow businesses like yours to do something about the crisis in the midst of it. It's now 2023. It seems like a lot of things have changed for you and your business. I'm wondering if you can walk us through that delta, because before we were recording, you said something interesting where it's like you'd almost wish that some of the changes that had happened during the pandemic hadn't. It might have made things easier for your business. And I think it's really important for us in this podcast, but then also for Canadians who are trying to get a grips of like what their healthcare should be to understand your position.
Yeah, so we've seen, I would say, a lot of regression since those days of the early pandemic, and I'd say regression just in the world of virtual care, and obviously it's a different topic for all other parts of the universe that we find ourselves in. But when we looked at what was happening early pandemic to mid pandemic, there was very clearly a lot of fast decision making happening on the part of all of the entities that set healthcare policy. So the colleges of physicians, the colleges of nurses, provincial governments, and it was a rare moment in time because all of these entities were aligned, and they were all aligned on one objective, which is access to healthcare is critical. Access is severely constrained right now due to the pandemic. We do not want regulation of any kind to get in the way of access. So what we saw is the colleges of physicians basically saying we are going to be very permissive of physicians practicing virtually, and we're going to take a lot of the restrictions away that might have existed before. And government said, we're going to fund virtual care where we never did it before. Lots of developments that just made it really easy to grow in this business. Then what we've seen since then, unfortunately, is I think this whole industry exploded. Lots of healthcare started happening online. And we saw a lot of the powers that be, with the determination made that maybe the worst of the pandemic was behind us, reverse course, and we've lost a lot of that alignment. So a lot of the funding that existed from provincial governments disappeared. So there's whole provinces where virtual care is not publicly funded anymore. There are some provinces where it is funded, but at drastically reduced rates versus the initial funding that came out during the pandemic. Those are all very problematic. What is even more problematic, I would say, is the positions that many of the regulatory bodies have taken. So if we look at what's happened at the various colleges of physicians and nursing colleges, we've seen increasingly restrictive policies enacted towards the practice of virtual care. So an example of a virtual care policy, which I would say is very regressive. We've seen this in a couple of provinces like British Columbia and Quebec, and actually even a little bit so in Ontario, where we've seen provinces where the colleges have basically said to a clinician or a physician, you are not allowed to treat any patient in the virtual world unless, if during your visit you determine a in-person physical visit is required, unless you personally can render that physical visit within a very short period of time, which is a day or two. And so what that really means, so I'm not going to question their intentions. It was probably made with the best of intentions, which is to say, we don't want you seeing a doctor where they're going to just pawn you off if they can't help you virtually. But the reality is, there is a massive amount of people in this country. There's 6 million Canadians that don't have family doctors. Most of them are rural. There's a massive number of people that there are no doctors nearby them physically that are accepting patients or could see them physically. And so for these patients, a lot of them, the only lifeline to care was virtual care. And so what we've effectively done is we've said, because you are in a bad situation, you're in a place where no physical care is available, now what we're going to do is we're going to discriminate against you. We're going to say, not only are you kind of I'm going to use the word, probably it's a word I shouldn't use in the podcast, but not only are you screwed because there's no physical doctors near you, we're going to doubly discriminate against you and say you can't see a virtual doctor either. And so all those people in Canada who are lucky enough to have a family doctor, who live in an urban region where there's lots of in-person doctors, they don't have any problems. They can continue.
Well, as someone who lives in an urban region, I would also say finding those care providers in a timely fashion, or it is also a problem. Like, not to dismiss the remote needs, but there's a lot of people living in downtown urban environments in major cities that are, within close proximity to doctors, but can't seem to get a booking in any reasonable regard, right? Or going to effectively triage walk-in clinics for that.
Yeah.
Not to counter your point, but just to extend the state of emergency that we're kind of finding ourselves in.
I agree with you. Yeah, no, and what you're doing is actually even backing up my point even more, because even in urban areas, and I'm trying to paint more of a black and white picture, but even in urban areas where it's really hard to get access to a doctor physically, one of your lifelines was still virtual care. Now, if you're one of these people that has no family doctor that's willing to see you physically in a day or two, now you're not allowed to access virtual care. So we've essentially taken a bunch of regulatory bodies that really stepped back and they were able to see the forest rather than the trees. And they said, we get that restrictive policies will hurt everyone. We need to prioritize access. Prioritizing perfect access will result in almost no access. So we have to just prioritize access as a whole. And now what we've seen happen is most of the regulatory bodies and the governments as well have said, we can't see the forest for the trees anymore. And now what we want is perfect access. And if somebody doesn't have perfect access, which is a virtual care appointment followed by in-person within 24 hours, we'd prefer they have no access at all, which, as we know, for millions and millions of Canadians is actually the case. And so now we find ourselves in a really awful place where many, many Canadians now are actually having the worst possible outcome, which is when they get sick, there's zero care at all that they have access to. And I don't think anybody would ever make the argument to say that virtual care, even in its worst form, where there's no physical care available, where it's just a virtual appointment and you can't see a family doctor for a week after that, or a doctor in person for a week after that, nobody would argue that that's worse than seeing no doctor at all. And that's, I think, where things have landed, unfortunately.
It's funny because it's not a huge conceptual leap. It's not like you have to game this out to the 98th leaf of the tree to figure this out. That's the part that I find mystifying. I agree with you that there's good intentions, or there's probably something going on there, but it doesn't take too many steps to be like, this is what the outcome is going to be. And furthermore, I mean, you were in the news, I'd say maybe 2.5 or so months ago, quite a bit, while the provinces and the federal government were arguing about what the money should be used for. Should we get more money, and what should that money be used for? And you are being critiqued not just for the offering of things that, but like stuff that regular GPs wouldn't even provide, that's not covered by the health insurance plan of a given province. Why does that affect your ability to operate if they're like, well, we won't cover this stuff? You could still theoretically, not that you should, but you could theoretically offer Maple to do, like, you want a physio referral? Okay. Like, that's a bad example. I'm not a doctor, so I don't know what our off book.
This is the part of the podcast where we let everyone know that we are not doctors.
I'm definitely not a doctor.
Obviously, the doctor is on this podcast.
I'm a proctologist, but I'm not a doctor.
Yes.
So, So, does that you were being impinged both on your apparent doing stuff that doctors are supposed to quote unquote be doing, which you've addressed because there's not enough capacity. But then there's the stuff that doctors don't do, so they can still use Maple for that. But even that has come under fire.
Yeah, can you even start by reminding our audience who didn't catch the previous episode, like how the payment structures works in the different provinces? Because I think that's going to point to some of the cages that you find yourself trapped in on either side, depending, right? Yeah. But I don't think most Canadians understand right now how the system works for your services. Yeah, exactly. or how their care gets covered.
Yeah, so it's a pretty straightforward framework in Canada. So what the laws say in Canada is that Canadians should not be paying out of pocket for what is considered medically necessary physician services. So each provincial government then makes the determination of what services do we think are medically necessary and what services are not medically necessary. And so for services that are medically necessary, the provincial governments are then obligated to provide a billing code for those medically necessary services that physicians can bill to provide that service. And that's always been the way that it is. And anything where the provincial government does not provide a billing code. So a good example would be laser eye surgery. There's no billing code for laser eye surgery because no provincial government has said we think this is medically necessary, despite the fact it's a valid medical procedure. It treats a valid medical problem, which is that you can't see distance. None of them have said this is medically necessary. So therefore, if you want laser eye surgery, you can pay out of pocket. You have to pay out of pocket. That's just accepted. And nobody has ever attacked laser eye surgeons for charging out of pocket. It's well understood that because the government doesn't cover this, this is something that is a private pay service. So in our neck of the woods, in virtual care, there are some services that are covered and some that are not. So in most provinces, a video call between a physician and a patient is a covered service. It's been determined to be medically necessary since the pandemic. And there's a billing code for that. Although that is variable in some provinces, it's only covered if you see your family doctor and not covered if you're not seeing your family doctor. But that's the basic premise. Now, in no province in Canada, with one exception, is secure messaging between a doctor and a patient covered. So if I, as a doctor, am giving you health advice via a secure messaging platform like what's in the Maple application, and I don't see you by video, I just do secure messaging with you, there is no billing code for that. So that's just like doing laser eye surgery. I've now performed a service that the government says is not medically necessary. Similarly, there's no province in Canada that has said services performed by nurse practitioners are medically necessary. There's no billing code for nurse practitioners to do anything across the country. So now we provide a lot of these services on Maple, and that's part of how we're able to provide healthcare to now 4 million people across the country. And that's how we're able to get access to healthcare providers in under 10 minutes, typically about 7 minutes, because a lot of our visits are covered with secure messaging, which vastly expands the number of doctors that are available, because a doctor who's sitting in his pajamas at home is much more likely to be willing to do secure messaging versus video. And again, nurse practitioners, we use them widely because there's a lot of parts of the country where there's just way more nurse practitioners than there are doctors available to actually provide care. So now the way we've continued to provide access to those services is to do exactly what the laser eye surgeons are doing, which is they're charging privately because it's not covered by the government. But what we've seen is this whole discussion become a highly politicized discussion and something that was really used to score political points by people who I think are more interested in scoring political points than the health and well-being of Canadians. And so we've seen, unfortunately, one of the leaders of a federal political opposition party, namely the NDP, decide to directly target our company for offering these services that are not covered by provincial governments, and essentially taking the party line, which is it's wrong for any Canadian to pay out of pocket for any healthcare services, and taking the position that this needs to be stopped. And what we saw is the federal Minister of Health wading in with an official statement that was given to say that they believe that what we're doing is wrong and against the spirit of the Canada Health Act, and therefore there should be some action taken to stop our company from doing this. So that's kind of where we find ourselves right now. That the next steps are unclear. What I understand is the federal Minister of Health is going to be issuing what's called an interpretation letter out to the provinces, which is going to spell out to the provinces the fact that the federal government expects the provinces now to cover these services, things like secure messaging, nurse practitioners. What's very unclear is how are the provinces supposed to pay for this, because they just don't have budget for this. So I'm not sure where all of this is going to land. But what is extremely, I would say, disappointing about all of this, just so disappointing, is we are in a time of the worst healthcare crisis we've seen in Canada, probably ever. 6 million people without a family doctor. The vast majority of people who do have a family doctor can't get an appointment for at least a week. People cannot access healthcare. We see emergency departments closing, clinics closing. It is really close to a collapse of the system across the country. And when we look at where is the federal government saying, we need to prioritize, what should we do to fix this big problem that no one has access to healthcare? It's shocking to me that in this time of access being the critical problem here, their solution is let's just ignore the problem and let's try to shut down a company that is actually providing access on a 24/7 basis to 4 million people. So let's actually exacerbate the problem. So, the right answer from my perspective would have been, we think what Maple is doing is working. We don't like that people are paying for it. How can we step in and actually figure out a funding model that allows this to actually work without people paying for it? Let's learn from what this company is doing and let's expand it and make it even better for everyone. I'm not hearing that. What I'm hearing is somehow we're the devil, close to being Satan, and the worst thing that's happened to Canada since the War of 1812, according to some politicians and the CBC, and we should be shut down. So that I think is sort of my up-to-date summary on the topic.
I mean, that's the etymology of this podcast, Brett, which is, shit's broken. See, you can say screwed because I said shit. Shit's broken. And we seem to be languishing in the combination of unforced errors. And what I'm trying to figure out here is our political solve for these problems seems to be, hey, it's okay if pharmacists now start prescribing, doing things that doctors used to do. Hey, it's okay that in Ontario, private clinics can deal with a backlog. Or in BC, Alex, we'll send some people down to Washington, to DC. We'll send people down to the States to do some of the services because we just can't handle the backlog. But with respect to the local innovation, it's like, no. If you other the problem, it's cool. But if it's happening within the borders of Canada, it's not cool. So that is the most concerning thing. And I guess the question, let's start with you, Brett, and then go to you, Alex. I want to go back to the question that Douglas asked at the very beginning. As an innovator in healthcare in Canada, you said, holy cow, it was amazing. Now, holy cow, it's painful. How do we unscrew ourselves? How do we allow people like both of you to create businesses, companies, solutions for Canadians and not shoot ourselves in the foot while doing it, both as entrepreneurs and building the capacity and pushing towards the future of where we should be, and literally killing Canadians while we figure this out?
It's a big question. I've got a lot.
I know.
Yeah. So I try not to eat up the rest of your podcast because I have so many thoughts on this. I think we need wholesale political change. We've had, for lack of a better word, we've had very cowardly leadership for a very, very long time when it comes to healthcare. We've had leadership for decades now that has looked at the Canadian healthcare system as a leader on the global stage and has made the determination that the way that we do healthcare in Canada is the only way to do healthcare, and has largely turned their backs on the rest of the world. And when they reference any other model of healthcare in the rest of the world, all they ever do is look at the big bad United States and say, wow, people are dying in the streets because they don't have insurance. We don't want to be like them. So we're great because we're not like them. And unfortunately, what we've seen happen over the several decades since the Canada Health Act was brought into existence in 1984 is we've seen progressively more and more politicians just ignoring all of the success examples that we see in other parts of the world. So if you look around at the rest of the Western world, every single country in the Western world, be it France, Switzerland, Sweden, New Zealand, Australia, Japan, Germany, I could list them all off. Every single one of them does not have this bizarre fear and prohibition on the private sector being involved in healthcare. Countries that are far more socialist than ours, like the Scandinavian countries like Sweden, Norway, et cetera, that are very, very further left on the spectrum than we are. All of them, except that the private sector has a very strong role to play in supporting the healthcare system and innovating in the healthcare system. But in Canada, for some reason, we've decided to be the only country in the world where private sector involvement in healthcare is somehow a dirty word. And I somehow think that comes from our proximity to the US, where they're the only country in the developed world that also has no universal healthcare system, which is their big problem, not that the private sector is involved at all. So I think Canadians are starting to change their minds on this, and they're starting to change their minds because our healthcare system, which is the only one in the world that functions this way, is just going off the rails in terms of its inability to deliver any good care or access to people in this country. And what we've seen is a very dramatic shift in public opinion on this topic. So whenever Canadians have surveyed on this topic as to whether or not they think we should actually consider some amount of privatization in healthcare, the answer has always been no. But what was interesting is in February of this year, so not that long ago, just a few months back, Ipsos actually did a national survey of Canadians on the topic of, do you believe Canadians should have the right to pay for private access to care if the government's not delivering those services in a timely manner? 60% of Canadians said yes. So the Canadian population has actually made up its mind. They've said the system's not working. There's lots of reasons why the Canadian population has drifted in their opinion, but what is very clear is the politicians aren't listening to Canadians. Politicians are pandering largely to their base, and we've seen that in some of the politics we've been subjected to. And I think politicians in general have been acting very cowardly, which is they know healthcare is this issue that if you bring up privatization, that you're going to get attacked left, right,
the third rail.
And it's not the thing that's going to win you an election. It's the thing that's going to lose you an election. So they all stay away from it. And this is the fear that has led us down the path to this completely dysfunctional, about to collapse healthcare system. So I think what we're going to see is more and more debate on this topic as our healthcare system goes further and further down the drain. And at some point in time, I think the healthcare debate is going to become the debate that will get people voted out of office if they don't have big, bold new solutions. And I think the cowardly approach is not going to pay off for very much longer. At least that's my hope.
My friends, let's cut to the chase. You're a founder, an entrepreneur, you're hungry, you're fast, you're agile, and you need a legal eagle that matches your pace. The answer? This episode's sponsor, Good Lawyer. Now, this isn't your grandpa's law firm. Good Lawyer is the trusted legal partner of thousands of businesses nationwide, boasting fixed-fee legal projects and their revolutionary fractional general counsel. And look, I'm no lawyer. I can't tell you what tort law means, only that it sounds delicious. But when BetaKit found itself in a labyrinth of legalities, Good Lawyer stepped in, delivering results that were as efficient as they were cost-effective. Plus, Good Lawyer's fractional general counsel isn't just versed in the law, they become versed in your business. They stand in the trenches with you, offering practical legal advice that fuels your momentum. So visit goodlawyer.ca today to see for yourself and tell them that BetaKit sent you. Right. Okay, Brett, Rob asked you a bunch of questions and bundled together, and you gave a bunch of really interesting answers that I think we want to unpack and then get Dr. Greenhill in on the other side. But I think maybe the pivot here is to challenge you a little bit, because I think everyone understands that the system isn't working. But to the statements that you're making around privatization, and the cowardice on the political end, I have to just note here that we're also dealing in an environment where in certain provinces, particularly ours, we have a premier that has been dramatically underspending, underfunding the healthcare system, not beyond the prescribed budget, but well below the prescribed budget, potentially intentionally to forward privatization agenda to maybe enable certain friendlies within his space. So I think the sentiment that you are speaking to in that poll isn't coming from evaluating a system that has been operated as intended and might even be undermined towards change. Not to dismiss maybe the points that you were making up top in terms of why, like, there are certain things that are privatized that we pay for now that no one considers to be a problem. Why are these new innovations being considered an issue? Or why are you being raked over the coals for offering something that, as we noted off the top, like local Canadians can't get? But I just have to step in here and say that there are more elements here than politicians being unwilling to address the system. There is an obvious underfunding and lack of care towards the system as outlined that is making it more difficult. And maybe to the point of where we started this conversation, the people that are now preventing you from having the codes, the subsidization, the funding that you had 2 or 3 years ago are the ones right now, like, pulling that away from you. So we just got to note that off the top, because I know there are a lot of people across this country who are very much concerned about becoming the United States while still concerned about the current state. And I think what we're trying to do here is maybe parse some of the solutions, some of the improvements, where those lines are between the right way of doing private versus the wrong way. Maybe certain offers that your company has that should be publicly funded. Why can't that be consistent? Like, there's a lot of red tape here across the board that nothing makes sense. In taken as a whole, none of this makes sense, but I really think we need to parse out the specific components that are working or not working and why. So that throat clearing out of the way, Alex, we need to get you in here for your perspective, either identifying points where you agree, with Brett in terms of solutions, or maybe even just come in on what you see is not working right now? That might be an easier place for us to all get on the same page.
The one thing I just want to add on top of it is, Alex, you've been out of BC. You've been running in this system, building companies for quite a long time. So you have a lot of experience in the ebbs and flows pre-pandemic. Like Maple's a rocket ship. It's been around for a while, but you've been doing this also for quite a long time. So you've seen the ebbs and flows, recessions,
other
and all
pandemics.
That other stuff. Yeah, exactly. SARS, for example.
Yes, exactly. I mean, so it's interesting because I've practiced in Quebec, Ontario, and BC, and I still practice in BC. I call it a license to heal, and I plan to continue to use it. And I've also been in a lot of leadership positions implementing change. So when I was an Emerge Doc at the Jewish, we were paper-based. And so living through that sort of a journey to digital, which was overpromised and underdelivered, all kinds
Still
of good
ongoing.
intentions. Yes. And sort of have a very different perspective, maybe because of that sort of continuous existence in all camps at the same time. Right, which is, as you're in a leadership role, by continuing to practice, you see it differently than people who are isolated in an office and hear a report. The report says, patient-centered care is here. Go to any hospital in Canada and they'll tell you that we're patient-centered and we value providers, we value mental health. And, when we make statements like everything's broken, it's actually not entirely true. My patients with a heart attack can walk into any emergency room, get a, like a surgery done within, same day, be discharged home within 3 days, have access to reasonable support and continued care. Except, a kid with mental health issues gets placed on a waiting list for 9 months until they can see a psychologist, and they have to pay $250 out of pocket for that care. And so those things don't make sense. But within my lifetime of practicing, which is just over 5 almost years, is cancers that used to kill patients are now not a problem. Like colon cancer, early detected, we do surgery, we do treatment, people go back. It's a shock to the system, but they survive. People with HIV can have kids without HIV. Like there's so many miracles that we have actually accomplished. And the reason we are running into issues now is that people who used to die quickly don't, and they live with longer lifespans and health spans, and they accumulate conditions. And so the average patient now has 7 health issues, not 1 or 2. And they're like post-transplant, post-cancer with heart failure and whatnot. And that complexity, the system was not built to withstand because it's not a system. It's a collection of hospitals, clinics, providers who are all trying their best, but it's like an orchestra that doesn't know what the script is, doesn't know who the conductor is, and so much of the effort is dissipated into discussions that are very black and white at the top of private, not private. And instead of looking at where you guys were pointing me, what are the problems that I see? Every time I practice, about half of my clinic are people who could receive care, but are not receiving the right level of care because of massive wait lists and conditions that are not popular because they're rare, they're not as acute. So like if you're having an urgent problem, not a problem. If you live in a big city, not a problem. But it's not fair that somebody with breast cancer can't get surgery for 6 weeks, even if they live in Vancouver now. But if they're in Prince George or somewhere else, rural Ontario, it's even longer. And then they have to pay themselves for the travel to the hospital, parking and food and lodging and all kind of other services. And so how can we collectively start having dialogues where the solution needs to be co-created? Because private can't create the technology without the input of the providers. And the providers should not be expected to build their own tools. Like, in business, you don't build, Google Suite, Microsoft Office, Apple phones. Like you buy a service that allows you to do your day job. And so how can we stop these nonsense conversations and start focusing on real people, what their needs are? And when I say people, that includes the patient and the family, but also the providers and the decision makers. I'm friends with a lot of people who are decision makers in the system who will answer texts and messages, work long hours all week, trying to make sure the surgical suites stay open, that they can recruit the right number of people. And so everyone's burnt out right now post-COVID. And what you're seeing is that collective fatigue. And I think that we need to have more co-creation and conversation. And instead of having divides and sort of looking at big political solutions, we need to have more of a discussion of what's actually wrong and what's the systemic cause of that, as opposed to the quick band-aid solution of like, let's fix the emerge room. Like, why is the emerge room so full? How can we support better GPs in the community?
Yeah. How did that become the first point of contact for most Canadians? Anyways, I think so. Point incredibly well taken, and a wonderful time for you to come in and maybe like recalibrate the tenor of this conversation, because I think we were kind of going to that. I really hear you when you say this isn't a circumstance where everything is broken, but there is frustration there and there is burnout, and I think there is concern it's going to get worse. And it is very helpful for us to look at the specific points where things aren't working and why. And I want to go back to Dr. Belchetz because I kind of countered what you were saying previously and then didn't give you a chance to respond. But I think what Alex is saying here at least resonates to what we were talking off at the top, where it just doesn't seem to make any, if you look at this as a system, any sort of coherent sense when you place some of these considerations beside each other in terms of like what is covered, what is not, what is prioritized, what is not, what is paid for, what is not, where you are in Canada dictating what types of access that you have, certain experiences that you have. Brett, I want to give you an opportunity to respond to that, but see if we're getting closer on the same page here, because we should be noting here that there are many, many people in the health system that are working very hard, hoping for better outcomes, and they don't have the support right now.
Yeah, so I think first of all, just in response to your comment, I mean, I hear you, and I think there's a big discussion around how much to what extent should we be increasing funding of our healthcare system here in Ontario, and has it been deliberately underfunded is another question. What I will say is the poll that I referenced is a national poll and actually was broken down geographically, and they looked at what the preferences are province to province, and in fact, what was interesting is. You had said that the outcome in that poll may be related to places like Ontario, where we're underfunding it potentially deliberately. In fact, one of the lowest percentages of the population wanting private healthcare was Ontario. In fact, in other provinces where you couldn't make that same argument of deliberate underfunding, there were even higher percentages of Canadians that were saying that they actually wanted to see a change. And so, I don't think, and I just want to clear up a misunderstanding. I don't think that private sector is the fix to all of what ails us. And I also don't think everything is broken. I think I've worked in the emergency room for decades as well. And there's some things that we're really good at, a lot of things that were awful. And I've seen a lot of my patients have really bad outcomes because a CT scan that I should be able to get in about 1 hour takes me 8 hours to get in the ER, and somebody has a bad outcome. So even for emergent care, a lot of the time our system is failing. But all that being said, I don't think the private sector is the fix to all of what ails us, but it certainly isn't the devil that our country paints it as. And the picture that I'm trying to say is that if we look at the rest of the world, all these other developed world nations like UK, France, Switzerland, et cetera, they're not burning in flames because they allow the private sector to be involved in healthcare. They're doing just fine. So I just want to.
Can I just say as well, I fully second that and reinforce, like, we wouldn't be having you on this podcast if we didn't think that the service that your company provided was helpful or useful. And honestly, part of the exploration we went under during our pandemic series of podcasts is like, why wasn't this like, where was this before? Why did it take us all being like, I recorded that episode with you remotely in lockdown because my partner couldn't leave the house. This was long before any sense of a vaccine or any, it was like I think this was like 1 month into the pandemic, right? So I think it's noted. I also don't think that you should be having to defend paying for things that people necessarily want. But I do think there's an argument in terms of like why it's incumbent upon your company to make those arguments. And maybe that's where we get to what Alex was saying, a little bit more of a systemical, like, parsing through that. But it should be clear to our audience that we wouldn't be having you on if we didn't think that your innovation that your company was providing that's useful for Canadians.
No, and that's helpful, and I appreciate that. I think the other thing you're asking about, and I think Alex was alluding to this as well, one of the critical shortfalls of the way that we're funding healthcare, and in our space, virtual care is I think a space that I'm more acutely aware of. It is when our governments have said, we're going to fund virtual care, we think virtual has a critical role to play in the healthcare system, which, I'll never say everything should be virtual. There's no way that makes any sense. There's tons of stuff in a physical exam we can't do virtually, but for about 50% of things, you can probably do it pretty well virtually, and you don't need to have people travel across town, sit in the waiting room, and cough all over each other to take care of them. So we should be treating those things virtually. But the problem that I see is that when the government says we think virtual care should be funded, and to date, when they have said we are funding virtual care, what that means to them is we're going to create a billing code for a doctor to see a patient virtually, and that's all it means. There's no other funding that they think about when they think about virtual.
And that's, sorry, just to interject, because we never got to this. That's the funding that you were referring to off the top that had changed, because I think maybe some of our listeners or viewers that hear funding when it comes to tech innovation might think like venture funding, operating capital. Like in this context, the funding is there's a billing code that covers this expense for care.
Exactly. It's a billing code. A doctor is billing to get paid by the government when they perform this kind of care. So the problem with that definition of it being covered, that it's now considered covered because there's a billing code for a doctor, which now even a lot of those have been withdrawn, or in Ontario, it's been cut in two, which is now it's $20 for a doctor to see a patient by video. And it's almost impossible. Doctors generally are not going to see a patient for $20, so it might as well not be covered. But the argument that I would make is that for virtual care to actually really make a difference, so the way that we have it make a difference at Maple, the way we're able to expand capacity of the healthcare system. And so we have a very, very complicated system that allows doctors to jump on and off the platform, Uber style. We have really, really sophisticated algorithms operating in the back end to ensure that when you come on, we're going to find a doctor somewhere in your geography that is available to see you right away versus you only have access to your own doctor and they may not have an availability for 7 days. There's a lot of work that goes into doing virtual care well. And we have great projects with some governments in Canada. Like we have a very good partnership with the Nova Scotia government where we operate a provincial virtual care platform for them that they license from us. And it actually allows our tech to allow all of their doctors to massively expand the care that they can provide to patients without family doctors in the province using their existing physician workforce. What I want to circle back to is to provide virtual care that way. The way that we do it is very, very, very expensive from a technology and infrastructure perspective. The coding, the engineering, the servers, all of that is massively expensive. I mean, you guys cover technology. You know that building technology does not come cheap. And so now a government goes out and they say, okay, great, we're going to pay a doctor $35 to see a patient virtually. Virtual care is covered. Well, what pays for the multi tens of millions of dollars in infrastructure required for virtual care to actually be effective in helping our healthcare system? That's not covered. That's not funded. Yeah. And that's one of the big problems. So what we've seen a bunch of virtual care players that have said, okay, the way that we're going to try to fund virtual care is we're going to take a percentage of the doctor's payment. So we'll ask the doctor to give up 30% of that $35, and out of that 30%, which is like $8 or $9 per visit, we're going to pay for our millions and millions of dollars of digital infrastructure. And of course, that doesn't work. You have these companies that are perpetually losing money, and most of them have actually disappeared as a result of dwindling funding and bad business models based on that. So I think, the parallel.
Well, I'm wondering which companies you've, because we were going to talk about, to Rob's point specifically about we're much more comfortable about this stuff happening in the US. We've also seen a variety of Canadian companies or otherwise move into the US, either because it's a larger market, so there's a larger pie there, or because of the privatization, they make it cost more, drive more revenue. Part of the prompting, the genesis of this is that we had some listener submitted questions about pair therapeutics going belly up. And it's like, what does this mean for Canadian health tech implications? And we're like, well, geez, every Canadian health tech company that we talk to is usually looking to commercialize in the US because it's so difficult here. Yeah. Are you kind of pointing to that draw? Alex, let's get you in there.
You're hitting something that is, when people say virtual, it can mean anything from phone calls to video calls, to remote patient monitoring, to pair therapeutics, which is this sort of a gaming almost design. And so we have confusion over the terms. And when people say patient-centered, it usually implies a conversation about me without me. Is a whole bunch of people have gotten together and talked about the patient, but they haven't really informed the patient or family in a way that's more just verbal or a few pamphlets. And so bringing the patient into digital should be the definition of patient-centered and patient engagement. But it's too easy to use words and create a check mark of, we have something. And so the reality of my practice is that anywhere in the country, the only way I can communicate with a pharmacist and create multidisciplinary care around a complex patient is by
Fax machine.
faxing them. It's phone calls, right? You're right.
And it sounds like a joke. It sounds like a joke, but it's insane that we're at that point, right?
It is. And, when we built Medio, which was the first telehealth directly to patient in 2012, it was so complicated. And one of the things we did is we created a clinic ourselves that used our technology. And so what Brett is describing is like, everyone's like, oh, private care. All of your GP offices and a lot of the specialist offices across the country are small businesses that rent, hire employees, provide a service based on a fee that they're paid for through the private public insurance, but they are running that as a private operation, and no one has a problem with that. Suddenly, when that goes virtual, everyone says the motivation of those doctors will change. And you're like, no, we still have to meet the same norms. And so, let's take out some of that black and white finger pointing and say, do you need to see someone physically to examine them in order to make your professional opinion? And if the answer is no, it should be paid the same way, whether we're sitting face-to-face in an office or face-to-face through a camera. And so what
does the technology behind the
is,
messaging service really affect the standard of care? Like
it actually does positively. Because I can see my patient's home surroundings, I can call their bluff on, yes, everything's fine at home, right? Is mental health, young men in particular, are more comfortable talking to me as a woman from a digital surface rather than face-to-face in an office. People don't want to show up to a mental health hospital. They prefer to do that from the anonymity of their home. And so there's tons of evidence showing that mental health virtually can actually be more effective than in person.
Yeah. 100%. I'm just saying that we shouldn't be charging different amounts or covering different amounts based upon what technology is used. The best technology for that level of care should be used. And we shouldn't be like, oh, my doctor accidentally texted me instead of calling me, therefore this is going to cost me $100 because he can't cover. Like I think that's where people get really frustrated about the Byzantine system of this. It's like, you were talking about the transition from paper to digital. Well, if the digital is just as confused as the paper trail was, then we haven't actually improved anything. We've just added another layer of complexity, right?
In the US, there was a number of law cases. They tried to do this a decade ago, and the courts overturned the ruling that insurance companies were trying to do less of a coverage for virtual, because they said it's the same collection of data and data points, the same training that goes into making a decision virtually as in person, and it's not fair to pay. And so there will be a sorting out of what's happened in Ontario, but in BC, we're lucky to have a government who understands that these things need to be equal. And the thing that I want to see more of is we actually had a press release go out this week with a big partnership with Trillium Health Partners and collaborating on creating jointly the new solution for Ontario health teams, where Careteam as a private company is engaging and bringing in a coalition of other private companies to make the job easier for decision makers. Instead of hearing from a myriad of small companies, create a solution that takes away the mental effort for them to figure out, how do I fit all of that into a continuum from acute care to community? Because otherwise, what's happened right now, it's so easy to build an app. Everyone with good intentions says, my uncle had a problem with name disease X. I'm going to build a solution and try and sell it to my local hospital. And the hospitals are just overwhelmed with good ideas that don't have privacy, security, technology. What Brett was describing, it's so easy for people to say, why can't we just use Zoom to do healthcare visits? And it's not about the video. It's about the setup. It's about the screening. It's about identifying who is available. And all of that does take millions to build.
Yeah, I think like a couple points. One is that, I to your point, Alex, I don't know if this is true for Maple or if the other telemedicine providers that you worked with, Alex, but like when I was building the OTN, we built all these amazing things, digital stethoscopes and dermatology things and all this stuff. I think it was like 87% of the consults were psych. Like they didn't need all of this crazy equipment. It was just like looking at the patient. What's going on? That's right. Okay, let's get out. So that I thought was kind of humorous. I don't know if is that still the case for telemedicine generally? It's, or at least something that doesn't require equipment, specialty equipment, but the doctor can ask a bunch of questions and do the diagnosis or differential on the phone.
Are you saying we don't need to shrink them down to the size of a white blood cell to go in?
That's right. That's next. That's AI. Is that true? I'm just curious, is that still true, or is
Well,
that
there
not?
is.
Is it a little more
Nowadays,
balanced?
we have digital
No? Okay.
solutions, right? From the sound of your voice, a software built in Chicago can guess your blood pressure, heart rate, looking at flushing, coloring, pulsation of your temporal artery, like all of these
Totally.
things are coming. So we will have digital virtual signs very soon without devices.
But the reality is, the vast majority of medical visits are pretty transactional, and they don't require those peripherals. I mean, it's somebody coming in for their prescription renewal. They're on thyroid medication and they've got all their levels. It's being well monitored, and they keep track of their blood pressure at home and everything. Like you don't need that digital stethoscope in that visit, and so on and so forth. There's lots and lots and lots of medical visits where we don't need to listen to somebody's lungs. We don't need to look in their ears. And so, I would love to see a day in the future where, we have affordable remote diagnostic kits like this that allow us to listen to everybody's lungs while they're in their home and look at everybody's ears and to get their vitals. But the reality is we don't need it for at least half of the medical visits that are coming in the door. Most of the stuff is super transactional.
And we did studies in real office visits. Only a third required a physical exam. So 2/3 of visits in a real office is you and the patient sitting across from each other, potentially infecting yourself with COVID or God knows what else, and frustrated because you had to travel across town and contribute to climate change for essentially a verbal interaction.
Yeah, or waiting outside of the clinic because they won't let you in because of COVID and it's the middle of winter.
Or you don't have a GP, so you have to do that because
standing
you don't
outside. Yeah.
So maybe we'll do this. And leaning in, actually, Brett, the point that you made about the Nova Scotia is interesting because that same Ipsos survey showed that the most dissatisfied with their own system are Nova Scotians. They're the ones who are most dissatisfied with the public system. So it's funny that you're white labeling Maple for them. But I think we're lucky here. We've got 2 doctors, video conference. So first of all, I have a problem with my elbow, and I was wondering if you could...
Don't go there.
Secondly,
we literally did that
you
to
bill
Brett
that
last
guy. Bill
time.
that guy.
Literally
this BetaKit can pay. But here, let's do this. Let's start with you, Alex, and go to Brett. You've spent a lot of time ebbing and flowing with the businesses that you've been building. And it seems to me that technology is not the problem. Building shiny new things that shoot lasers from your eyes doesn't seem to be the problem. Things like billing codes, which are like course metrics for success. It seems to me like the technology is not the problem, it's the process that's the problem. And so are we stifling innovation in healthcare by having entrepreneurs such as yourselves build companies because the process is broken? Or is it a technical thing? Like, what is it? So what is your prescription? Such a bad pun.
No, we're doing
Alex
it.
and Brett,
lean into it. It's the
what
title
is
of the
your
podcast.
What do you think, based on all of your knowledge in building all of these companies, what do we do? What would you do how do you use the levers that you have to push your ability to help and not being a public servant? And what should we do? What do we do?
Before prescription comes a diagnosis.
Diagnosis.
The interesting thing
patient is dying.
We're the
we
not
know the
doctors.
patient is dying.
If people haven't figured this out yet, we are the not doctors in this conversation. Yeah.
The interesting thing is that you highlight the difference between invention and innovation. Bruce Mao, a Canadian who leads a massive change, talks about how you can invent the electric car, but you need to figure out rules and norms about how do you make it safe for pedestrians who can't hear it coming. How do you charge it? Self-driving car, same. Like once you invent something, you need to figure out how does it actually work in real life with everything else. And if we had that right, we would do this for AI, social media, and we would realize that, hey, maybe there's a risk of people becoming addicted to social media or, misuse of it for political purpose. Like all of these things could be thought of ahead of time. And yet one of the things we typically do is we let the invention out in the loose and we blame the user for saying like, hey, you should be using it, but why aren't you? And it's our job as innovators to figure out how do we actually engage with others to make all of that possible in real life. And what's missing, and that's the prescription of what I would say, is what's missing is the next step after a pilot. We have tons of funding for pilots, but you've proven this works for 1,000 patients. How do you now make it into something that other people can take, like 10 other clinics like this one, and prove that it works as well? And you mentioned the US bigger market and whatnot. The reason a lot of companies go to the US is speed. It takes me 3 weeks to meet with the VP of innovation at Kaiser. It takes me 6 months to get the same meeting somewhere in Canada, and it's not going to be with the VP in innovation. And so that sort of a funding for the scaling piece is sorely missing. And healthcare keeps reinventing new tools that we then sell to the US or elsewhere. And it's hard to sell in the US because the first question they ask is, where is it used in Canada? And if it's not used in Canada, why not? What's wrong with your innovation? And so if we can figure out that funding, and Cant Health has been a good step in that direction, Community X gotten funding, Baycrest Cabby has been hugely helpful. We need more of that. We need it more ubiquitously accessible. And we need translators, people like Brett, like myself, who live both realities and can help the innovators understand how incredibly busy the day of an administrator in a hospital or clinician is, and how difficult it is while they're saving literally people from fires, to think about a new tool, to start using it. And just think about new devices in your own life. How many people get a new laptop and don't open it for like a week or two because it's so difficult to transfer?
Rob and I just look at each other like we are literally the people in our families that helped them set that thing up.
Yeah, exactly.
That's our contribution. So Brett, is your answer basically, please give me access to whatever spreadsheet the billing codes are kept on, and I can solve our system in like 15 minutes? Like, is it that to the point of innovation and like that implementation? Like, if we could just billing code everything, we'd be fine.
No, actually that probably wouldn't be the answer. I mean, I think number one, what I would look for is stability. The rules of the game change every 6 months. From a College of Physicians standpoint, they're constantly publishing new guidelines on what's allowed virtually, what's not. From a billing code perspective, it's constantly changing. So it's really, really hard to exist as a business when the rules of the game just change on you so frequently. So that's number one. Number two is, we look at ourselves as a technology company. Primarily we've built a platform that allows more physicians to provide more care than they would have without our platform. So when we started the platform, we saw a problem, which was not enough access to doctors in the country. We saw that if you look at the Stats Canada numbers, a very significant percentage of Canada's doctors are not working fully or full time. And we said, can we build a platform that lets more doctors use some of those available hours to help more people that couldn't get help? And that was our platform. I don't actually even want to get involved in the billing code issue at all. I don't want to be making money charging for healthcare services. I don't want to be making money taking a percentage of a doctor's billing. What we are is we're a technology solution. And I think for us, what would be fantastic would be for governments to say, there's two elements to providing virtual care. Element one is we're going to pay the doctors when they practice virtually. We're going to give a good billing code that makes sense. And we're also going to pay for technology that we know costs tens to hundreds of millions of dollars to provide at scale. And the same way that we very happily write a check to Epic for $250 million for one hospital to have an Epic system, we're also willing to contract out to technology players like Maple, who can provide a provincial scale virtual care platform or a hospital scale virtual care platform. Because if we really want effective virtual care, not only do we have to pay the clinicians, we have to fund the technology. So that, for me, would be the answer. And then I think the third element, and I think Alex put it really effectively, is how do you get things to be scaled up? How do you get people the opportunity to, when they try to go to the US, say, yes, I've done it in Canada. I'm going to give you a really good example of where Canada goes really wrong in terms of commercialization of innovation. So it is almost impossible for a interesting, promising, innovative company in Canada to get a large government contract. It just doesn't exist. They go out with huge RFPs. The only people that ever win the RFPs are the big incumbents that are either Canadian or international. Like you as a small scale up almost have no chance. And what we've seen actually even in some of the big RFPs is even where we're very well positioned, one of the big incumbents here in Canada will underprice us in a money losing bid just to make sure that we don't get it, because they don't ever want to allow us to get that big market presence. So price being a number one determinant on our RFPs is just an awful way that we do business. And in those cases, actually, what's funny is when those incumbents have won 2 years later, they still haven't launched a program that we could have launched in 3 months. So that's another story. But the story that I want to tell you is how they do things differently in a country that has actually been very successful at taking innovators and giving them commercialization opportunities. And as much as there's many things wrong with this country, they're a great success in innovation, and that's China. So a great example coming from China is they, as a country, a number of years ago said, we think electric vehicles are the future. We have no electric vehicle industry whatsoever. We have no production capabilities. Nobody believes we can create a quality EV. Nobody in another country is ever going to buy a Chinese EV. There's no chance. And so they said, what is the pathway? We want China to be the leader in electric vehicle manufacturing, which in fact today it is now. There are more electric vehicles being produced by local Chinese companies in China than any other country in the world. How did that happen? It wasn't because the Chinese government said to innovators, you guys are on your own, go figure it out. And hopefully in a dogfight against some of the other incumbents and in RFPs that are based on lowest price, winning the RFP, we hope that you guys win. And maybe if you do that, you'll emerge. What they said is very purposefully, we want to be a global leader. So what we're going to do is we're now going to very purposefully give commercialization opportunities to this field of starting out innovators in the EV production world in China. And they said, we have an order for 10,000 buses in Beijing. Here's the contract. Like you're going to have to deliver, but we're going to give that contract opportunities to one of these promising scale-ups. We're going to have a fleet of taxis in another city. We're going to give that. A fleet of electric garbage trucks. We're going to give that. And so what ended up happening is over many, many years, or not even that many years, over a number of years, now what happened is these Chinese companies, because they were getting these huge commercialization opportunities from the Chinese government, the ones that failed and didn't deliver are gone. They've disappeared. The ones that really delivered and succeeded are now world beaters, because now when they go and they say, hey, it's time for us to sell an electric car in the United States or Europe, they now have hundreds of thousands of vehicles under their belt that they've produced with the backing of the Chinese government to get them on their feet. And that is what we do not do in Canada whatsoever. We say we want to be leaders. And then what does our government do when there's a big digital health infrastructure project out there to fund? They say, we'll give it to Epic. So of course, no Canadians are emerging and becoming world beaters because they can't get their footing here in Canada. So that for me is one of the number one things I would love to see, is that when we look at how do we support innovation here in Canada, it isn't just, SHRED grants and IREP grants. It's we're going to give you real commercialization opportunities that you can springboard into real sales in other countries once you've succeeded here.
He must have listened to our episode 2 episodes ago with Ben, but
So no, well, hey man, we also
Alex.
did a procurement episode in the health tech context like a year ago. So these are, the diagnosis and the prescription, I think, are known at this point. It's the level of action. And I think, Brett, to some of the points 2 and 3 are really well taken in a week of our recording, where the federal and the BC governments show up to drop $300 million on Upcellera. Meanwhile, right? But hey, we appreciate you both coming on this podcast and talking it through. This is a really, really important conversation for every Canadian. And I hope they appreciate the perspectives you've provided, because again, not doctors, actual doctors, but in that other sphere of tech and industry, and able to connect those dots for us. So
and I think we should pick this up again if we can, and because it's moving so quickly.
Yes.
Both our system is in trouble so quickly, and the changes to both of your points are happening pretty quickly within both of your business. It's important, I think, to circle back and sort of keep checking in and seeing what Canadians can do to support and change the system. And also, maybe next time we can talk about innovators in the health space and what does that mean for new entrants, and what should they be thinking of?
Yeah.
Those are great topics. And Brett, I totally agree with your last points. I mean, there's so many things that are going right. Digital supercluster, more innovation for more complex, but we need buyers. We need people. When I was in San Francisco, they said they have 4 C's. They have coders, concept, cash, and customers. And so without the early adopters, the valley would not be the valley. That was the mayor of San Francisco who said that. And, we need more of that as individuals, as organizations, and as governments, to understand that Canadian innovation should not just be an export, but we should be the first ones to benefit, because why wouldn't we want our families and friends to have better access to better tools?
Yeah. I don't like my friends.
No, health begins in the home. That's the positive way. Let's end on a positive note. Thank you again.
Thank you.
Pleasure being here.
Thanks.